Good morning. I am Pinak Shah. I am the director of the Cardiac Catheterization Laboratory at Brigham and Women's Hospital. And over the next 40 minutes, I will be giving a broad overview of aortic stenosis as well as transcatheter aortic valve replacement, or TAVR, which is becoming the near standard of care for patients with severe aortic stenosis. And here I've listed my disclosures. And I refer you to these two documents. On the left is the 2014 AHA-ACC guideline for the management of patients with valvular heart disease, a very extensive document that reviews every valvular abnormality and management of each anomaly. And on the right is the 2017 focused update, which includes guidelines regarding the use of transcatheter valvular therapies. What I've shown here is the guideline classification system. Class 1 recommendations are those where the treatment is indicated or useful and should be utilized. Class 2 recommendations are those that are reasonable, with Class 2A being those where the benefits seem to outweigh the risk, and Class 2B perhaps less benefit but overall should be beneficial. And then Class 3 recommendations are those that we should not be doing. And each classification is broken down by the level of evidence. Level A evidence is evidence that is secondary or based on high-quality randomized trials or meta-analyses. Level B are guideline recommendations that are based on moderate quality randomized clinical trials or meta-analyses or non-randomized data. And level C are recommendations based on those that have limited data or perhaps based on consensus opinion. I will first start out with just the basic evaluation of aortic stenosis. Aortic stenosis is perhaps the most simple valvular abnormality to understand as well as to work up. All that is needed to make the diagnosis of aortic stenosis is a good history and physical exam, as well as a transthoracic echo. That is generally the only test required, and that is a Class 1 recommendation. It is rare that invasive hemodynamics are required to make the diagnosis of severe aortic stenosis. However, it is indicated in situations where the non-invasive imaging data is discordant or inconclusive, and that is a Class 1 recommendation. We stage the severity of aortic stenosis based on several criteria from echocardiography. They include the valve area, aortic velocity, as well as the mean gradient across the aortic valve. So patients are considered to have severe aortic stenosis if their valve area calculates to be between 0.6 to 1 centimeter squared, or if they have a peak velocity across the aortic valve of blood flow of 4 meters per second, or if they have a mean gradient greater than 40 millimeters of mercury. In addition, the aortic valve index can also be used, and that is severe when it is less than 0.6 centimeters squared per meter squared. Of course, patients can be symptomatic with moderate aortic stenosis, and just because a patient may be in the moderate range doesn't mean that they don't require treatment. But in general, patients with severe aortic stenosis, particularly those that are symptomatic, will go on to treatment. And this is a nomenclature that is now being used more frequently in describing patients with aortic stenosis. This is an aortic stenosis staging system based on the AHA-ACC guidelines. Patients who are Class C or Stage C aortic stenosis are patients who have severe aortic stenosis with a peak velocity across the valve of 4 meters per second or a mean gradient greater than 40 millimeters of mercury. However, Class C patients are all asymptomatic. The difference between C1 and C2 is LV function. If patients have preserved LV function, they are C1, and if they have LV dysfunction or reduced ejection fraction, they are stage C2. Patients who are Class D or Stage D are all symptomatic with severe aortic stenosis. D1 patients are the classic severe symptomatic aortic stenosis patients, patients who have the typical symptoms of AS, that is dyspnea on exertion, perhaps angina, exertional lightheadedness, or syncope, and they have a peak velocity across the valve of 4 meters per second or a mean gradient greater than 40 millimeters of mercury. Stage D2 patients are patients who have so-called low flow, low gradient, low EF aortic stenosis. These are patients who have a reduced ejection fraction and may not generate a gradient that is in the severe range. In other words, their peak velocity may be under 4 meters per second, or their mean gradient may be less than 40 millimeters of mercury. Typically, these patients are evaluated with a dobutamine stress echocardiogram to increase the cardiac output. And if this generates a peak velocity across the valve greater than 4 meters per second, or a mean gradient greater than 40 millimeters of mercury, then this would be suggestive of severe aortic stenosis. And then there is stage D3 aortic stenosis, perhaps the most difficult group of patients with aortic stenosis. They are symptomatic and they have severe aortic stenosis. They have what we call low flow, low gradient, but normal EF aortic stenosis. These are patients who have a low velocity across the valve or a low mean gradient across the valve, but their stroke volume is reduced, and a stroke volume index less than 35 milliliters per meter squared makes the diagnosis of stage D3 or paradoxical low flow, low gradient, normal EF aortic stenosis. So who do we treat? Well, it is a class 1 indication to treat patients who are stage C2 or D1. It is a class 2A recommendation to treat patients who are C1, D2, or D3. We do not generally treat patients who are class B, who have progressive aortic stenosis or moderate aortic stenosis. That is a class 2B indication. And what about the timing of treatment? Well, the class 1 indications for when to treat patients with aortic stenosis are the following. It is recommended for symptomatic patients with severe high gradient aortic stenosis who have symptoms by history or on exercise testing. And those are patients who are stage D1. It is recommended for asymptomatic patients with severe AS, stage C2, with a reduced ejection fraction of less than 50%. It is also indicated in patients with severe aortic stenosis, stage C or D, when undergoing other cardiac surgery. Another important concept in the modern era of evaluation of valvular heart disease is the heart team. Now that we have therapies that are both surgical and transcatheter, there is a multidisciplinary approach that is now used to evaluating patients with valvular heart disease to determine the optimal treatment strategy. So it is presently a class 1 indication for patients with severe valvular heart disease to be evaluated by a multidisciplinary heart valve team when intervention is considered. In addition, it is a class 2A recommendation for consultation with or referral to a heart valve center of excellence for patients who are going to be considered for treatment options for severe valvular heart disease. If they are asymptomatic, to determine if they may benefit from valve repair versus replacement, or patients with multiple comorbidities for whom a valve intervention is being considered. Another concept that is gaining a lot of attention right now is the assessment for patients in terms of their risk for open heart surgery. And using a risk assessment paradigm is how we determine what the best treatment therapy would be for a patient, be it a surgical approach or a transcatheter approach. The first tool that we used is the Society of Thoracic Surgeons Predicted Risk of Mortality score. And this is something that can be calculated using a multivariable model that can be obtained simply from the internet by simply going into the Google search and typing in STS predicted risk of mortality. You'll come up with a model where it will ask for patient characteristics such as age, height, weight, and other clinical characteristics, and give you a predicted risk of mortality at 30 days from open heart surgery. If the STS score is less than 4%, that patient is considered a low surgical risk patient. If their STS score is between 4 to 8%, they are considered intermediate risk. And if the STS score is greater than 8%, they are considered high risk. In addition, there are patients who are so high risk that the STS score may not be valid, and these patients are considered prohibitive risk. Now, the STS score is the initial risk assessment. What is ultimately required is a surgeon's assessment of that patient. In other words, a patient may have a low STS score, but could be considered a higher risk patient if they have other multisystem organ compromise, if they have indices of frailty, which may not be measured by the STS score, or if they have a procedure-specific impediment that may make surgical therapy high risk, such as a porcelain aorta. So in general, surgery has been the historical gold standard for the treatment of patients with severe aortic stenosis. But in the modern era, Many, and in some institutions, most patients are now being treated with a transcatheter approach, that is transcatheter aortic valve replacement. On the top row here are the FDA-approved devices for TAVR in the United States. The SAPIEN 3 valve by Edwards Lifescience is a balloon expandable system that is delivered from a transcatheter approach. And then there are two self-expanding platforms from Medtronic called the Core Valve. There's the Core Valve Evolute R and the Core Valve Evolute Pro. In 2019, we expect approval of two other platforms. One is the Lotus platform from Boston Scientific, and the other is the Portico self-expanding platform from Abbott. What I've listed here are the clinical trials of transcatheter aortic valve replacement therapy versus another treatment option for patients, either medical therapy or surgical aortic valve replacement. As you can see that over the last 7 years, there have been thousands of patients enrolled in randomized clinical trials of TAVR compared to another medical strategy, either medical therapy for patients who are inoperable or surgical aortic valve replacement. And in every one of these trials, TAVR has proven to be non-inferior, if not superior, to the other treatment option. And we'll review each of these trials in detail. The first randomized clinical trial of TAVR, the Partner B cohort, was published in 2010. This was a randomized assessment of patients who were considered inoperable for standard surgical aortic valve replacement. These patients were randomized to undergoing a transcatheter aortic valve replacement versus continued medical therapy. And you can see that these patients have a very high overall mortality out to 2 years. However, TAVR reduced their mortality from 50% to 30%, a 40% relative reduction in mortality with transcatheter aortic valve replacement. The study utilized the first generation SAPIEN transcatheter heart valve, and the catheter sizes required for delivery of this device were markedly large compared to what we are using today. But even with this very first generation device, a very early device that was by no means perfect, we showed a significant reduction in mortality with transcatheter aortic valve replacement. Core Valve did a similar trial in extreme risk patients. This was a single-arm study that compared their outcomes to an optimal performance goal based on prior clinical studies. It was estimated that the 12-month survival or 12-month mortality in patients with severe aortic stenosis who were inoperable in this study, 43%. But patients who were treated with the first generation Core Valve device had a 26% mortality, which was well below the performance goal of 43%. The first generation Core Valve device was a much smaller system than the SAPIEN device. It required a smaller catheter for delivery, 18 French, and there were more sizes available for use. Based on these two studies, TAVR became approved for patients who were inoperable for standard cardiac surgery. We then started studying these devices in patients who are high risk. These are patients who could undergo standard surgical aortic valve replacement, but they were high risk for this particular procedure. The Partner A cohort was a randomized trial of high-risk patients to undergo surgical aortic valve replacement versus transcatheter aortic valve replacement, again using the first generation SAPIEN device. This was designed as a non-inferiority study. In other words, transcatheter therapy had to be shown to be non-inferior to surgical therapy, and in general this would have been felt to have been a major benefit given the less invasive nature of transcatheter therapy and the quicker recovery. And in this trial, out to 24 months, you can see that mortality was no different between these two groups. In other words, transcatheter therapy was indeed non-inferior to surgical therapy. Now, transcatheter aortic valve replacement can be done via multiple routes. The most commonly performed route is a transfemoral route, but there are patients who don't have significant or who do not have sufficient iliofemoral sizes for transfemoral placement. And early on, we utilized the transapical approach in those patients. But what you could see in the Partner A cohort is that patients who were treated transfemorally overall appeared to do better than patients who were treated with surgery, although this did not reach statistical significance. However, when we looked at the transapical cohort, these typically tend to be sicker patients. In general, transcatheter patients did not do as well. In fact, if anything, they did worse after 2 years. CoreValve was also studied in high-risk patients. This was a randomized study of patients with severe symptomatic aortic stenosis who are high risk for surgical aortic valve replacement, again utilizing the first-generation CoreValve device. And what you can see is that out to 12 months, the patients in the TAVR arm did better in terms of mortality compared to patients in the surgical arm. This not only met the endpoint for non-inferiority, but it also met a superiority endpoint, suggesting that patients do better with TAVR than surgical aortic valve replacement if they are high risk. Therefore, based on the outcomes of these two trials, TAVR then became approved for patients who were high risk for surgical aortic valve replacement. We then studied these devices in patients who were intermediate risk. So now moving down the spectrum of risk. And in the PARTNER 2 study was a randomized trial of transcatheter aortic valve replacement versus standard surgical aortic valve replacement in patients with severe symptomatic aortic stenosis who were intermediate risk for surgical aortic valve replacement. This study utilized the second-generation SAPIEN XT device. It was smaller in size and came in more sizes, making it applicable by the transfemoral approach to more patients. And what we can see in this non-inferiority study is that throughout the 2-year follow-up period, when we look at death or disabling stroke, overall, TAVR appeared to perform better than surgical aortic valve replacement, and this met a non-inferiority endpoint. When we look at the transfemoral cohort, which was the majority of patients, this actually met a superiority endpoint compared to surgical aortic valve replacement. I mentioned this study, the Intermediate Risk Registry, which utilized the SAPIEN 3 third-generation device, which was now even smaller than prior devices. This was a registry, but it was a propensity matched comparison to surgical aortic valve replacement. These were all intermediate risk patients, and what this study showed was that mortality was actually lower with transcatheter aortic valve replacement versus surgical aortic valve replacement, nearly a 50% reduction at 1 year, and this ultimately led to approval of the third-generation device. And the CoreValve folks also did an intermediate risk study called SUR-TAVI that was published in the New England Journal of Medicine in 2017. 75% of the patients in the study received the first-generation CoreValve device. 25% received the second-generation device, which was smaller and was able to be delivered through a 14 French system. And what this study showed was that TAVR was non-inferior to surgical aortic valve replacement in patients who were intermediate risk for surgical aortic valve replacement. Therefore, based on the PARTNER 2 study and the SUR-TAVI trial, TAVR became FDA approved for patients who were intermediate risk for surgical aortic valve replacement. Therefore, today in 2018, the only group of patients who are not FDA approved for transcatheter aortic valve replacement therapy are patients who are low risk for surgical aortic valve replacement. Now, TAVR has performed extremely well in these clinical trials, but there are some limitations of TAVR that should be taken into consideration, particularly as we start exploring this therapy in low-risk patients, patients who would do well with standard surgical aortic valve replacement. And I've listed here, in my opinion, what are the 5 major potential downsides of TAVR. They are stroke or cerebral emboli, paravalvular regurgitation, need for a permanent pacemaker, leaflet thrombosis, and finally, durability. When we look at stroke and TAVR and we look at the clinical trials that I've just discussed, we see that early on the stroke rates were unacceptably high, upwards of 7% in the PARTNER B cohort. Now, in all of these trials, neurological events were adjudicated by neurologists. Therefore, the sensitivity for picking up a neurological event was much higher. So these rates may be higher than we see clinically in the real world. However, as time has gone on in these trials, as our devices have become more advanced, as we as operators have become better at this procedure, as the patient risk levels have come down, stroke rates have come down to a very acceptable 2.4% in clinical trials. And what about in the real world? Well, in the United States, any center performing transcatheter aortic valve replacement is required to report their outcomes data to the Transcatheter Valvular Therapeutics Registry. And in the early look of this registry, in the first 43,000 patients that were submitted, we saw that the stroke rate was 2% in-hospital stroke in patients undergoing TAVR. And again, these are site reported strokes, not neurologist adjudicated, so this may be lower than the true number, but in general we feel that the stroke rate is about 2%, which is in line with surgical therapies. We do now have an FDA-approved device that can help reduce embolic material to the brain. This is the Claret device, the Sentinel device, which consists of 2 filters that can be delivered through the radial artery. One filter protects the innominate, which would then, on the right, which would then protect the right carotid artery and the right vertebral artery, and the second filter protects the left carotid artery. The left vertebral artery cannot be protected with this device. And in a clinical trial of this device in TAVR patients, overall we saw a reduction in stroke rates with the device, although this did not reach statistical significance. I do not show the data here, but this study also showed a significant reduction in embolic material to the brain as measured by diffusion-weighted MRI. Another potential limitation of transcatheter aortic valve therapy is paravalvular regurgitation. And what this is intended to show here is color flow through the valve on the outside of the valve indiastole, suggesting that this patient has important paravalvular regurgitation. And what causes paravalvular regurgitation? Well, unlike with surgical aortic valve replacement, where the surgeon has direct visualization of the aortic annulus and can directly sew the new valve into the old aortic annulus, during transcatheter aortic valve therapy, the valve is actually delivered through a catheter and is either released by a self-expanding system or is released through a balloon expandable system, but we cannot and do not have direct visualization of the annulus and its contact with the new device. Therefore, there can be areas where the new device does not completely conform to the annulus. The risk factors for developing paravalvular leak are if the prosthesis chosen is too small, if the prosthesis is deployed either too high or too low in the annulus, if there is severe left ventricular outflow or annular calcium as shown here in this CT scan, or if the annulus is irregularly shaped. And why is this important? Well, first of all, in the PARTNER 2 study, we see that if you compare patients who underwent TAVR versus surgery, in general, TAVR patients are more likely to have paravalvular regurgitation. And in particular, I point your attention to this group, the patients who have moderate to severe paravalvular regurgitation. You see that this is almost never seen in surgery, but can be seen upwards in 3 to 4% of patients with transcatheter aortic valve replacement. And the reason this is important is that in PARTNER 2, as well as prior clinical trials of transcatheter aortic valve replacement therapy, we saw that patients who have moderate to severe aortic stenosis, paravalvular regurgitation are much more likely to have worse outcomes out to 2 years. And these outcomes include congestive heart failure and mortality. Therefore, it is imperative that we minimize the number of patients we treat with TAVR who have moderate to severe aortic insufficiency, as these patients do worse. Now, there have been some design modifications of the transcatheter valve systems to help reduce paravalvular regurgitation. Both the SAPIEN 3 and the CoreValve Evolute Pro have now been designed with a sealing skirt at the base of the valve so that this comes in contact with the annulus. It actually expands in the presence of blood flow to help seal leaks. And we have seen significant reductions in paravalvular regurgitation with these modifications. In the SAPIEN 3 high-risk registry, we saw that moderate to severe paravalvular regurgitation was reduced to 2.6% overall, down to 1.2% in high-risk patients. And in the CoreValve Evolut Pro registry, again, only 60 patients, so a small study, we see a moderate to severe paravalvular regurgitation rate of only 1.7%, which actually resolves over time. What about pacemakers after transcatheter aortic valve replacement? We do see patients develop heart block after TAVR because of the fact that the AV node and the His bundle system lies in the LV outflow tract just underneath the aortic valve annulus. Therefore, when we manipulate the aortic valve annulus with wires, catheters in the device, the electrical system can be traumatized, resulting in heart block. It is certainly going to be a higher risk in patients who have baseline conduction disease, including right bundle branch block, bifascicular block, and we also see a higher risk when the transcatheter valve is placed lower and there is greater interaction with the left ventricular outflow tract. We have also noticed that in general, permanent pacemaker rates and paravalvular leak or regurgitation rates are inversely proportional. That is, any modification of the device to help reduce paravalvular regurgitation often puts more pressure on the annulus and the LV outflow tract, leading to a higher likelihood of needing a permanent pacemaker. When we look in the real world in clinical trials and we look at permanent pacemaker rates in the SURTAVI study, we did see a 26% need for permanent pacemaker in the TAVR group compared to only 6% in the surgical group. This is far higher than in the real world and certainly not what we would tolerate in our practices day to day. Of course, this study did use a first-generation device. About 25% of patients in this study were treated with a later device that has the ability to be retracted and repositioned so that an optimal position can be obtained. And as we have learned to place these devices more effectively, as the devices got better, our pacemaker rates are certainly much lower than this. We would not expect a 25% pacemaker rate in clinical practice. And when we look at partner 2A, using the SAPIEN device, we see pacemaker rates that are a little bit more in line with what we see in clinical practice. That is, patients in the TAVR arm had an 8.5% need for permanent pacemaking after TAVR, compared to 6.9% in the surgical arm. And the reason this is important is severalfold. First of all, we generally don't think of pacemakers as such a big deal. They are routinely performed, they are very safe, they rarely have complications in the long term. However, it is another procedure. It is another foreign body implanted into the vascular system that could have complications down the line. There's a cost associated. And we're learning that pacing patients with hypertrophied ventricles, such as those with aortic stenosis, may not be so benign. And in this study, recently published in JACC Interventions, it was shown that patients who did need a permanent pacemaker were more likely to be rehospitalized for congestive heart failure and were also more likely to die or have rehospitalization for heart failure out to 4 years. So we have to be very careful about keeping pacemaker rates very low, particularly as we expand this therapy into lower risk patients. What about leaflet thrombosis? This is a CT scan of a patient who had a transcatheter aortic valve, and what you see here is a lot of leaflet thickening in the aortic prosthesis, which is not normal and very much consistent with thrombus formation on the valve leaflet soon after transcatheter aortic valve replacement therapy. This issue came to light in this study in the New England Journal of Medicine that evaluated patients not only from the Portico study, but from a registry in Denmark, as well as a registry from Cedars-Sinai in California. These pooled patient populations include patients who underwent TAVR and surgical bioprosthetic valve placement. What they found was that thrombosis with reduced leaflet excursion was seen in one or more leaflets on 4D CT in upwards of 13% of patients. It was not reliably detected on transthoracic echo, and it was seen in both transcatheter and surgical bioprosthetic valves. Additionally, there was an increased stroke risk in patients with leaflet immobility, and it was less likely to occur in patients on warfarin. And furthermore, resolution was seen in patients who were started on warfarin. So the key take-home points from this are that this leaflet thrombosis problem is not unique to TAVR. It also occurs in surgical bioprosthetic aortic valves. And what this likely means is that patients do need to be on some form of antithrombin treatment in addition to antiplatelet therapy after transcatheter or surgical bioprosthetic valve placement. What the ideal treatment regimen should be is not yet known, and there are ongoing clinical trials at this time to determine what the best treatment strategy should be after transcatheter aortic valve replacement. And then finally, durability. One issue that we do not know is how durable are these transcatheter valves? Do they last as long as surgical aortic valves? And the issue here is that we have not been placing these valves for such a long time to have a long timeline of experience to understand the durability issues, if there are any. The best randomized data we have are 5-year outcomes from the PARTNER study. And what this study showed was that transcatheter aortic valves in the blue lines here compared to surgical aortic valves basically performed as well, if not better, than surgical aortic valves out to 5 years in terms of mean valve area, maintenance of a good valve area, as well as maintenance of a reduced mean gradient across the valve. What we really need to understand is how these valves perform 10 to 15 years out, and that data will likely be forthcoming, but still many years down the line. So just to summarize how TAVRs have performed in clinical trials, again, we see that death rates started out as high as 30% in the sickest patients, now down to 6 to 7% in intermediate risk patients out to 1 year. We see stroke rates that are way low now, than 2.4%. Moderate to severe paravalvular regurgitation in the 1 to 2% range, and permanent pacemakers are around 10%. There are 2 important clinical trials in progress. Now these are trials of transcatheter aortic valve replacement therapy compared to surgical aortic valve replacement in patients who are low risk for surgical aortic valve replacement. The first is the CoreValve low-risk study, which is still randomizing patients, and the second is the PARTNER 3 study, which has completed its randomization, and data should be forthcoming from this study within the next 18 months. In both of these studies, patients in both arms, the surgical and the TAVR arms, will be followed for 10 years, and that will be an important data set to understand durability issues with transcatheter aortic valves compared to surgical aortic valves. On this slide, I've shown the present FDA indications for transcatheter aortic valve replacement, as well as what it takes for a center to do TAVR for CMS to reimburse the procedure at that center. So first of all, the devices that are approved in the United States include the SAPIEN XT, which is rarely used now that we have the SAPIEN 3 device. Also, CoreValve Evolute R and CoreValve Evolute Pro are FDA approved. The procedure is approved for patients who are inoperable, high risk, or intermediate risk for surgical aortic valve replacement. And the minimum STS score a patient must have to be considered is an STS score of 3%. However, patients with lower STS scores can be considered if they are deemed intermediate or high risk from a cardiac surgeon if there are other features that are not captured by the STS score that may increase the risk level of that patient. All patients need to be evaluated by a heart team, and actually at the present time, all patients need to be evaluated by 2 independent surgeons to confirm that TAVR is the better approach. In terms of hospital requirements, a hospital has to do at least 50 surgical aortic valve replacements, at least 1,000 cardiac catheterizations, at least 400 PCI per year to be considered. There has to be an on-site cardiothoracic surgical program, and there has to be at least 2 surgeons on site. For individual surgeons to do TAVR, they have to do at least 100 aortic valve replacements lifetime, or have had to have done at least 25 in the past year or 50 in the past 2 years. And for an interventional cardiologist, they have to have had done at least 100 structural heart disease cases in a lifetime or 30 left-sided structural heart disease cases over the past year. And all centers have to report their data to the Transcatheter Valvular Therapeutics Registry. On this final slide, I will show the present guidelines for how patients should be treated with severe symptomatic aortic stenosis. Patients who are low risk for surgical aortic valve replacement, it is a Class 1 indication to be treated surgically. There is no indication for a patient to be treated with a transcatheter device if they are low risk, unless they are in a clinical trial. Intermediate risk patients, it is Class 1 to be treated with surgical aortic valve replacement, Class 2A for transcatheter aortic valve replacement. High risk patients, it is Class 1 either with surgery or with TAVR, and prohibitive risk patients, Class 1 with TAVR. Now, there have been a couple of changes. These are the most updated guidelines when we look at how things have changed from 2014. The addition of a Class 2A indication for TAVR for intermediate risk patients is new compared to 2014. And in 2014, TAVR was only a Class 2A indication. For high-risk patients, it is now Class 1. We'll now go on to the questions. This first question, this is an 83-year-old man with hypertension and diabetes who presented to his PCP with complaints of exertional dyspnea. His PCP detected a significant late peak systolic ejection murmur and referred the patient for an echocardiogram. The echocardiogram showed normal left ventricular function and severe calcific stenosis of a trileaflet aortic valve. The mean gradient across the valve is 47 millimeters of mercury, and the aortic valve area calculates as 0.8 centimeters squared. His STS score is 2.8%. He is referred for diagnostic coronary angiography, which shows no significant obstructive coronary artery disease. However, fluoroscopy shows a heavily calcified porcelain aorta. He's referred to the heart team at the Regional Medical Center in New England for consideration of treatment options. He is seen by an interventional cardiologist and a cardiac surgeon. The cardiac surgeon feels the patient is high risk for surgical aortic valve replacement due to the porcelain aorta, and therefore feels that TAVR is a better treatment option for this patient. Which of the following statements is true? A, the patient is not a candidate for TAVR given that his STS score is in the low risk range. B, the patient requires a TAVR protocol CT scan to confirm that the aorta is too calcified for surgical aortic valve replacement before it can be considered for TAVR. C, the patient requires a second surgeon to independently evaluate the patient and conclude that the patient is high risk for surgical aortic valve replacement before the patient can be considered for TAVR. C, the patient has completed his evaluation for TAVR and can be scheduled for the procedure. And E, the patient should be considered for participation in a randomized clinical trial of surgical aortic valve replacement versus TAVR in low-risk patients. The correct answer is C. So just in terms of why the other answers are incorrect, the patient does have a low STS score, but if a surgeon feels he is high risk for some other reason, he can be considered for TAVR. In terms of B, a TAVR protocol CT scan is required for the performance of TAVR for procedural planning, but it is not required to determine that the aorta is too calcified for surgical aortic valve replacement. D is incorrect because the patient has not completed his evaluation for TAVR and in fact does need a CT scan for procedural planning before TAVR can be performed. And the patient would not be considered for participation in a low-risk trial because this patient is in fact considered high risk by cardiac surgeons because of their porcelain aorta. So C is the correct answer. The patient does require a second surgeon to independently evaluate the patient, and if that surgeon also concludes the patient is high risk for surgical aortic valve replacement, this patient can be considered for TAVR. Question 2. A 90-year-old man presents for a heart team evaluation for management of a severe aortic stenosis. He has comorbidities that include stage 2 chronic kidney disease and mild reduction of the left ventricular function and a history of prior coronary artery bypass grafting surgery. He has New York Heart Association Class 3 heart failure symptoms, and his echocardiogram shows an ejection fraction of 30% with severe calcific trileaflet aortic stenosis. The peak velocity across the valve is 4.1 meters per second, and the mean gradient across the valve is 42 millimeters of mercury. He underwent a coronary angiogram and his bypass grafts are patent. His STS score is 10.3%, placing him at high risk. He was deemed high risk by 2 cardiac surgeons and felt by the heart team to be suitable for TAVR. He underwent a cardiac CT to assess annular dimensions prior to TAVR. This is an image from the CT at the level of the aortic annulus. Which of the following risks of TAVR should be emphasized with the patient during procedural consent based on this image? So here we see the aortic annulus, and we see a large calcified excrescence here in the aortic annulus, right where the valve will be placed. So the options are: A, his annulus measures too large for a commercially available transcatheter valve. B, he is at higher than normal risk for moderate to severe paravalvular leak after TAVR, which may be a marker for worse long-term outcomes. C, he has a 50% chance of requiring a permanent pacemaker after TAVR. D, he is at higher risk for valve migration or embolization during TAVR. Or E, surgical AVR is his only treatment option. Well, the correct answer here is B. He is at higher than normal risk for moderate to severe paravalvular leak after TAVR, which may be a worse marker for long-term outcome. And that is, again, because of that large body of calcium. It may prohibit perfect sealing of the transcatheter valve in the annulus. A is incorrect because his annulus measured within a reasonable range for any commercially available transcatheter valve. C is incorrect because left ventricular outflow tricalcium does not necessarily correlate with the need for permanent pacing. D is incorrect. He is not at higher risk for valve migration or embolization. In fact, the calcium would likely help stabilize the valve. And E, surgical aortic valve replacement, is his only treatment option, and that's also incorrect. He would actually be a poor candidate for surgical aortic valve replacement. And despite the fact that he has severe left ventricular outflow tricalcium, it does not mean that TAVR is impossible, and it does not mean that we wouldn't get a good result with TAVR. It's just that he does have to be counseled on the fact that he may have a higher risk for moderate to severe paravalvular regurgitation.